See what happens. Okay, now it says it's recording. Let me let Leanne in, and then
Okay.
we'll. Hi, here comes some more people in.
Hey there.
Hi, Leanne.
Hi.
Hey,
Oh.
Alice.
How we got here? Let's make that bigger. There we go.
Okay, so before Sally does Ken's introduction, I'm just gonna let you guys know that this is recording and that we may, this video may be used in the future outside of our Facebook group. So if anybody has any, if they'd rather not be seen or heard, then do what you need to do with that. But with that, I'll turn it over to Sally.
Here, I'll just change that.
So I'm excited, very excited to have Dr. Friedman with us, and he's a retired associate professor of pharmacology and physiology at the New Jersey Medical School in Newark, New Jersey. Dr. Friedman received his PhD from State University of New York in Stony Brook in 1970. During his career, he's conducted both basic science and clinical research and has received funding from the NIH. Currently, he's an adjunct professor at Rowan College of South Jersey. Dr. Friedman's expertise is broad, very broad, including topics, but not limited to membrane lipids, cystic fibrosis, the central nervous system, muscle contractions, cell membrane permeability, and following his daughter's contraction of MECFS in the early 1990s as a college student, he became an expert in the field of MECFS, including a special focus on pediatric diagnosis and management of the disease in children. Dr. Friedman has served over 3 years on the Chronic Fatigue Syndrome Advisory Committee for the U.S. Department of Health and Human Services, and is an advisor to 3 U.S. Secretaries of Health on issues surrounding MECFS. He holds leadership positions in several influential MECFS advocacy organizations, including currently chairing the Medical Scholar Committees of the New Jersey MECFS Association, a program that evolved from his original offering to his own medical students to promote increased knowledge of MECFS in the medical profession, to its current iteration, which awards a yearly scholarship to a medical student or resident receiving training in New Jersey who demonstrates knowledge of MECFS by writing an award-winning essay on the subject. And we are extremely delighted to have him with us today. Thank you so much.
Thank you. I'm glad that it was brief, because if you get to all what I have done over the years, it could probably take the whole time of a seminar. Is it possible for you to make me a co-host so that I can share my screen, my PowerPoint presentation?
I think you should be able to already.
I should be able to do it already? Okay, so let me see if I can do that.
And while you're doing that, Sally probably told you this, but I wanted to let you know that many of us in this group either have MECFS or have a family member or friend that does. So we're coming at it not just as therapists, but also as people living with the disease as well.
Right. Yeah. So I admire your courage and your fortitude for doing that, because I know how difficult this disease can be. So what I wanted to do today was to share with you my thoughts, which may be at this point radical, on MECFS, and to indicate what I think that physical therapists and occupational therapists can do and perhaps should do with regard to not only MECFS, but MECFS-like illnesses, which we will get to very shortly. And so the title of this presentation is Therapy, meaning physical therapy and occupational therapy, for a new category of diseases, which includes MECFS, which is post-active phase of infection syndromes, or which I like to call PAPIS, which is an acronym for that term. And if there are any questions, I don't know what the availability will be of this presentation. If there are any questions, they can be directed to me. My email address is simply my name, which is kenneth.j.friedman@gmail.com. So if you know my name and remember I use Gmail, you should be able to reach me. So part of my radical thoughts on MECFS is that researchers have been looking for the quote trigger of MECFS for approximately 40 years. And at this point, due to the development of the pandemic, namely COVID-19, and the sequelae of COVID-19, namely long-haul COVID-19, I believe that has been a mistake, because I don't think that there is necessarily a quote trigger for MECFS. I think that long-haul COVID makes it very clear that MECFS is not a unique disease, and it does not have a unique trigger. Rather, it's a condition which arises from a variety of illnesses. And so therefore, that is why I believe it is best to name the condition PAPIS and to think of it more in terms of a broad title of disease, somewhat analogous to the term cancer. We all know what the term cancer means, yet we would be very hard pressed to try and define what cancer means. All cancer are types of cancer. In other words, there are subcategories of cancer. But nevertheless, if we speak of the term cancer, we all know what cancer means because of the properties that all the various types of cancer have in common. The common properties of cancer are essentially symptoms or sequelae of the types of cancers that exist, and the symptoms of cancer, regardless of which form or type of cancer that one has, are generally treated similarly. If you want to treat the cause of the cancer, when you know the cause of the cancer, you can do that. But if you don't know the cause of the cancer, all you can do are treat the symptoms of it. And that is essentially the point we are at with MECFS. We haven't subcategorized it. We do not know the various types of MECFS, nor the types of other similar diseases, except perhaps for long COVID, where we know what the trigger mechanism for long COVID is. And so for those kinds of diseases, what we should do is we should apply the same symptom treating principles for MECFS as should be applied to other diseases that have these long duration symptoms after an initial active phase of infection. Again, PAPIS stands for post-active phase of infection syndrome. I formally announced, or we formally announced, our belief that this is the category of disease or diseases under which MECFS should be considered in a paper which was recently published in 2021. I am the senior author of that paper. There are 3 other authors of that paper, which are indicated at the bottom of this slide. This is an international agreement and collaboration throughout the Western world of science. We have Modra Moravska from Latvia. We have Derek Phoebe from the United Kingdom, and we have Paweł Zaluski from Poland. The issue or journal in which this paper was published, Our Evolving Understanding of MECFS, is an issue, a themed issue devoted to MECFS, which is guest edited by Derek Phoebe, and I and the other two junior authors are co-guest editors of this issue. So I cannot think of a stronger way of putting this proposal of recategorizing, rethinking about MECFS than what we have done and how we have formally introduced it. On a personal thought or note, I think that by recategorizing MECFS as a post-acute phase of infection syndrome, we will be removing some of the stigma that has been associated with MECFS because we are making it a sister illness to several other illnesses in general. So the themed issue that this paper is in a journal called Medicina. The original deadline for contributing papers was December 2020. That deadline has now been extended. So if you have anything that you feel you wish to contribute, you may do so until the end of July of 2021. And the website for that particular themed issue is indicated at the bottom of the slide here. Hopefully we can make this available, or just write to me if you need to have it in future. So as I said, PAPIS is a new way of classifying the lingering symptoms of infection. And what I would like to say now to further complicate or strengthen the argument is that I believe that the term will apply to both viral and bacterial infections, and that by using the term PAPIS, we can take what was previously considered unrelated diseases and put them in a classification where they now become related. Certainly, there seems to be little question that long-haul COVID will meet the criteria of being a PAPIS, and it is certainly true for the majority of cases for MECFS. Remember, or maybe you don't remember, but for a while, MECFS was once called long-term Epstein-Barr or chronic Epstein-Barr virus, because a lot of patients who had Epstein-Barr virus, also known as infectious mononucleosis, just never recovered. And so it became chronic Epstein-Barr. But that name gave way to several other names, and those several other names has now given way to MECFS. So the majority of cases of MECFS are believed to be viral induced or triggered. And so certainly MECFS would fall under the term PAPIS. When I announce or tell people that this is my belief, they say, well, what about the other MECFS patients that do not have a viral origin? Patients report that surgery or other kinds of trauma can induce MECFS or trigger MECFS. And I say that by the time you are a child, you have been exposed to viruses. Trauma causes changes in the immune system, and trauma causes those changes to permit those viruses that you already have and have concealed to become expressive. And so therefore, most likely, even if the initial trigger has not been a viral infection, there is a viral infection lurking in your body, and the correct immune conditions have permitted that virus to re-express itself. So at this point, the best examples that I could give for PAPIS are MECFS, which is a viral condition, long-haul COVID, which is also a viral condition, and Lyme disease, which is now classified as a bacterial condition. For those of you who follow the Lyme literature, now it's not quite clear whether Lyme disease is really one bacteria or several. All we know is that it is transmitted by a tick bite, but the actual bacterium or bacteria may now be up to question. Regardless of the causes of these infections, if these symptoms are expressed, the body reacts in a physiological manner or in an immunological manner, and therefore the symptoms are caused by mechanisms that can be considered physiological or immunological. And if you are going to try and treat those symptoms, that treatment will be the same regardless of the cause. And that is my heretical view of what is happening. Are there other similarities between MECFS and long haul COVID? Well, in theory, or in fact, the judgment needs to be out, because in my opinion, we don't know enough about either of the two conditions, but we can certainly look at what is available now for the two conditions. The usual duration for infectious mononucleosis, which is the primary cause of MECFS, is 2 to 4 weeks, but as we know, it can last longer and it can last up to 6 months. And the reason we say that it can last up to 6 months, because if it lasts up to 6 months or longer, then we say the person has MECFS. And that is the view of the Centers for Disease Control, and the reference to that is given here. And so what we want to do is to compare that duration of infectious mononucleosis and the onset of MECFS to that of COVID and long haul COVID, which is something which is difficult to do because it is currently unclear how long the recovery from COVID or long COVID should take. For COVID or long COVID, research reports indicate that people experience symptoms for 60 to 90 days after the initial infection, but some people experience symptoms for longer than that. And this is the opinion that's been expressed in Medical News Today as of March 8th. So this is a fairly recent summary of, granted, a layman's view or a journalistic view of MECFS, but we really haven't collected sufficient data on COVID and long haul COVID to be able to assess. But it is a ballpark figure or number. People who have been hospitalized, at least in the lay literature, are usually out of the hospital in 2 to 3 weeks, except if they experience severe COVID, in which case it can be up to months. And then what happens is they come out of the hospital, they go home, and then they realize that they have additional symptoms or they get more severe symptoms. Some of them go back to the hospital, some of them linger at home, but those are the patients who have long COVID, and we really don't know quite how long that they have. In terms of the incidence of infectious mononucleosis, there's only one study I call to your attention, and that's the work of Lenny Jason, who looked at over 4,500 college students. And in that population, 5.3% developed mononucleosis. And the important take-home figure is that 23% of those mono patients developed MECFS. And if we were to try and compare that to long haul COVID patients, it appears that approximately 1/3 of COVID patients or the survivors of COVID end up becoming long haul COVID patients. So you have 23% versus 33%. So that means that it's, I would say, for the loose kinds of data that we are dealing with, we're probably in the same ballpark. And this 1/3 of COVID patients developing long-haul symptoms is taken from WebMD. And again, it's a fairly recent 2021 reference. What's also very interesting is now that we have long-haul COVID patients enduring symptoms for 6 months or longer, many of them now fulfill one or more of the case definitions of MECFS. And so they may now be classified as MECFS patients, and they may now be treated as MECFS patients. So we do not know the percentage of COVID long haulers who will meet MECFS case definition criteria, but we can expect that we will be seeing more. So as physical therapists and occupational therapists, I suspect that they will be very busy and perhaps overwhelmed with patients who will need help attempting to conduct their daily lives because of their either MECFS symptoms or their MECFS-like symptoms. I guess I could interject at this point here that based upon the literature that I have seen up to this point, we can project based upon the number of MECFS patients that we had, I think it was at the end of March, we can anticipate a number of 3 to 9 million new long-haul COVID-19 patients in the United States. And if that is the case, there will be a doubling or tripling of MECFS patients in the United States, which will be very difficult for the current number of practitioners to treat. In defense of my categorizing long-haul COVID and MECFS as a PAPIS, there is this quote from Anthony Fauci, which was made in February of 2021, which says that he would actually prefer that long-haul COVID be considered by another name, and that name be PASC, which would be post-acute sequelae of SARS-CoV-19 infection. That quote and his announcement of trying to rename long-haul COVID as post-acute sequelae of SARS came about a week after we published our PAPIS definition. And so there is alignment, one of the few times there is alignment of Fauci and my train of thought with regard to these syndromes. And so I think one cannot escape the commonality of PASC and PAPIS. And I would say that whether you wish to call long-haul COVID that name or wish to rename it as PASC, it certainly falls under the category of PAPIS. So what we would like to be able to do is to argue that there is a similarity of MECFS and long-haul symptoms, which would then suggest that it is appropriate to treat those symptoms the same, namely that long-haul symptoms should be treated the same as MECFS symptoms when those symptoms occur in long-haul patients. So as far as I know, there are only two approaches with which to do that. There is the approach of comparing these long-haul patient syndrome inventories, which have been generated by MECFS patients and by long-haul patients. and comparing them. And I have attempted to do that along with my colleague. His name is Howard Sellinger. He prefers to be called Andy Sellinger. He is the chair of faculty medicine at the Frank Netter School of Medicine, which is part of Quinnipiac University. And we have produced a paper which has now been rejected by 3 journals who cater to family medicine, which is where we thought this paper should go. But at this point, what they have said is they are too busy and have too many papers to publish our paper, which implies that giving guidance to treating MECFS symptoms in long COVID patients is unimportant, which is not my point of view. So we're going to put this paper elsewhere to just get it out there. And so the primary care physicians who see these patients will just have to dig a little deeper to get this information. So we did compare or do a comparison of symptoms based upon symptom inventory to show the commonality of symptoms. And the other way of doing that is to search the literature of studies that have been prepared by professionals to show the commonality of symptoms. To my knowledge, there was not such a study ever done until I asked Danielle Weitzer, who is a third-year resident at the school of which I now have an appointment, namely the School of Osteopathic Medicine. Danielle Weitzer applied to our scholarship, the medical scholarship program, and subsequent to her receiving an award, we had a discussion about MECFS, and I was lamenting the lack of rigorous scientific review of the commonality of symptoms between MECFS and long-haul COVID. And she volunteered to speak to her supervisor, Tim Wong, and see if they would be willing to write a paper doing just that. They agreed to do just that. And so they did submit that paper, and they submitted it to our themed issue of Medicina. It sailed through peer review, and so now the first paper comparing in a rigorous manner based upon a review of the literature has now been published. So we can take a brief look at that. I apologize, it looks kind of boring, and for our study, the print is kind of small, but have faith, there is a summary at the end, so that I just want to show you the spread in the data and the lack of comfortableness that I have, but it does at least show a trend. So for Friedman and Sellinger, what we did was we created a table comparing the frequency of symptoms of MECFS and long COVID. The sources of the long COVID paper that I was able to glean was from the patient-led research for long COVID, the CDC survey of long COVID patients. UC Davis did a survey of long-term COVID patients, and the AARP, American Association of Retired Persons, also did a survey of them. So that is the long-term COVID side of the table. The MECFS sources that I was able to find were CDC surveys, National Health Service of the UK. They did a survey of MECFS patients. The Mayo Clinic did a survey of the MECFS patients. And our pediatric primer, which we published in 2017, has some data on in children of MECFS symptoms. And so those are the sources that I was able to glean. So let's just take a brief look. I'm just going to sail through these slides. The slides are hard to read, and I apologize for that. I tried to expand the print, but my skills are in PowerPoint, and migration of tables into PowerPoint is not that great. So the patient-led survey is under the long haul is the first column, the CDC is the second column, UCD is University of California, Davis, and then AARP is the fourth column. And then we migrate over to the MECFS surveys, which are the CDC, the National Health Service, again, which is the UK, MC, I forget what that is already. Let me go back. Mayo Clinic, and we have the pediatric primer. So to sail through these, as you can see, if X's or data goes across the boxes, that means that it is frequent. So for example, fatigue is found across the board. Post-exertional malaise, it's found in the patient-led survey of long haul, not in any of the other surveys of long haul COVID, but it's found across the board in MECFS survey, which is one of the problems. If you don't ask the question, you're not going to get the data. We have brain fog across the board, etc. And so that gives you some idea as to the kinds of data. So I'm not going to belabor the issue because there is a summary at the end here. So let's just get to that. So in terms of what we have gleaned from that, the common symptoms for both MECFS and long haul COVID are fatigue, post-exertional malaise, brain fog, dizziness, headache, joint pain, muscle, body pain, and heart palpitations. So for occupational therapist, physical therapist, if you can figure out ways to reduce those things and help your patient through those things, that would be wonderful, because those are their presenting symptoms. And I think that for most of the patients, those will be the symptoms that they will most frequently wish to have addressed, at least based upon patient surveys. With regard to what Tim Wong and Danielle Weitzer did, they did a systemic literature search. And what they did was they looked for studies of long haul COVID and MECFS in both Medline and PsycInfo. And what they were able to do is, when they saw the studies, they looked at them, and they were able to glean 21 studies that included qualitative analyses. And of the 25 known symptoms, or 25 of the known symptoms of MECFS were reported by at least one select long COVID study. So there were 25 MECFS symptoms in common with MECFS observed in long haul COVID patients in terms of their study. And the kinds of data that they got, how they reported their data for these long haul COVID studies, was that they looked at the number of papers in which these MECFS symptoms were reported in COVID papers. So that, for example, for the duration of symptoms lasting greater than, equal to, or greater than 6 months, that occurred in 7 of the 21 papers. Fatigue was reported in 8 of the 21 papers. And for completion, or for completeness, I put them all in here so that for reference, they are here. But we don't need to go through them. There is an author-provided summary, and this is what the authors gleaned from their study. namely that there is a high degree of similarity between long COVID and MECFS. Of the 29 listed MECFS symptoms, all but 4 were reported by at least one long COVID study. All 3 major MECFS criteria symptoms, namely fatigue, reduced daily activity, and post-exertional malaise, were reported in multiple studies, and fatigue was reported in 12 of 21 studies, which suggests that fatigue is the predominant symptom of long-haul COVID. So, in terms of guidelines for treating PAPIS, we'd like to propose that the primary care provider or any care provider use the guidelines that have been published for the treatment of MECFS that are appropriate for treating any PAPIS. My concern is that there is an ever increasing number of long-haul COVID treatment centers popping up in hospitals, and those hospitals are providing care based upon the disciplines of the symptoms without knowledge or regard for MECFS. Namely, they are taking clinicians who treat symptoms, but not necessarily the symptoms of MECFS, and are asking them to treat the symptoms of long-haul COVID without recognizing the symptoms of MECFS. MECFS does have some relatively unique symptoms that need to be considered, and those should be extended to all conditions that fall under the guidelines of PAPIS. For example, you should be educating the patient to minimize their post-exertional malaise by pacing his or her activities. And one way of doing that is to suggest that they perform small amounts of work with periods of rest interspersed in between the work they are doing. It may be possible, and it has been found possible in MECFS patients, to accomplish more work by doing it in small spurts with resting for long periods of time between it than trying to accomplish a task in maybe 2 periods with 1 rest period in between, rather than, let's say, 5 work periods with 4 periods of rest in between. And that may not be obvious to these long COVID clinical care centers. Patients should be made aware that they should be alert to how they feel when they are approaching the end of the energy that they have. They should be advised or counseled to use energy monitoring devices. The old-fashioned way is to use activity logs. The more modern way of doing that would be to use heart rate monitors. If the heart rate increases, it's a sign that you're getting tired, putting more energy in. You can also use step counters. You should attempt to understand, the patient should attempt to understand the relationship between activity and their energy limits. One way of helping patients is to identify and, if possible, treat pre-existing, which would now be comorbid condition. If the patient had a pre-existing condition which is now comorbid, if you treat that condition, the patient's health, overall health, will improve. And finally, patients are sometimes overwhelmed by a profound number of new troublesome symptoms that they have. And you can only treat one or a small number of them at a time. If you try and treat a large number of symptoms at one time, and the patient does not do well with a treatment for one of those symptoms, you will not know which treatment has caused the adverse reaction, in which case you have to start all over again. So it's better to make few changes at a time, and therefore it's better to treat something or the few things that are most troublesome and make those changes and have some success, rather than run the risk of treating a lot of symptoms and have failure because of the reaction to too many or one of the many treatments that you have tried. MECFS patients have reported pain relief, which is one of the predominant symptoms or symptom complaints, from some therapies that are not the part of traditional medicine, such as acupuncture, chiropractic, Pilates, and massage. Unfortunately, there are no formal studies of these. Nevertheless, it is certainly worth a try. I will say it here unless I forget to say it later. Namely, that I don't believe there are any formal studies of what the benefit is of these therapies on MECFS patients or long-haul COVID patients. And I certainly think that it is a worthy endeavor to try to have some report, some scientific or data-driven result with regard to the effectiveness of these other kinds of therapies for both MECFS and long-haul COVID. And finally, there is a cautionary note, namely that these symptoms, as has been observed in the lay literature, are very broad. No two patients behave alike, nor do they respond to specific therapies alike. And therefore, there will be variation in the effectiveness of any therapy in any given patient. So that therefore, we can say that there's a high degree of variability among patient responses, and therefore that makes it more difficult to characterize the response of a large group of patients. But as we are learning, the larger the set of data, the more trusted the outcomes of those data sets can be. So finally, we get to the conclusion and proposal, my plea, if you will, of this presentation. As you are probably aware, thanks to the Institute of Medicine study, there are an estimated up to 2 million MECFS patients in the United States. And based upon the analysis that we did in now my unpublished, but hopefully soon to be published study with my collaborator, Andy Selinger, there are an estimated, or was an estimated, 3 to 9 million Americans with long-haul COVID. That number may go up. The number of long-haul COVID patients that satisfy the MECFS criteria at this point is an unknown, because there just simply isn't enough data. But there are currently very few, if any, published studies with regard to physical therapy or occupational therapy induced improvement, not only for MECFS patients, but for long-haul COVID patients. And so I would very much like to see, even though I cannot do it myself, studies that involve these kinds of therapies on these kinds of patients. And so if we were to make the proposal that we classify MECFS and long-haul COVID patients under the proposed classification of PAPIS, the question arises as to what physical therapy and occupational therapies can be provided to improve patient outcomes. And from my naive point of view, not being a physical or occupational therapist, what I would propose is that you generate a list of projected helpful therapies based upon the symptoms, and you have the symptom list in this presentation. Articulate those suggestions, perhaps in a theoretical journal article, if you're anxious to publish. But I would suggest creating a mechanism, a collaborative mechanism for data collection and reporting the results for some of the most promising of these therapies. And then after you have results or lack of results even from trying these therapies for a period of time, you would have to be the judge of what would be a good clinical trial for attempting to improve patients' lives using the various modalities available for physical and occupational therapists. I would suggest that you write a manuscript indicating what therapies have helped and possibly even what therapies were not helpful to patients who fall under the category of post-active phase of infection syndromes. I am pleased to be able to announce that the journal for which I currently serve as a guest editor of a themed issue. Some of you may know that I am guest editor of a themed issue of healthcare entitled MECFS, the severely and very severely affected, has agreed to establish what they call a topical collection for PAPIS. This is a new endeavor, namely a themed issue for PAPIS. It just came this week. They agreed. This has been a negotiation. This will be the journal's Healthcare's third topical collection. A topical collection for them is that there is a guest editor for a topic, and papers are submitted to that topic on an ongoing basis, so that for PAPIS, papers will be and can be submitted on the topic of PAPIS to the journal, called to my attention. I will referee those papers, assign the referees for those papers, get them refereed, and once they are published, they will be marked or indexed as belonging to the PAPIS collection. And then at some point in the future, one will be able to retrieve all those papers marked in the PAPIS topical collection. Now, this is very new. It only happened this week. I have to write a subscription, or a description rather, of the collection, what it will entail. I have to write a solicitation for manuscripts and explain. I have to solicit the journal articles on an ongoing basis, but hopefully I will be successful in doing this. When I proposed the themed issue, MECFS, the severely and very severely affected, I was full of lack of confidence. There was not a single paper on MECFS, the severely and very severely affected. And I knew that I would have to solicit papers and attempt to get individuals, authors, to write papers on that topic. Fortunately, I was able to do so, and I believe last time I looked, we were up to 15 papers in that issue. We need 10 to be able to have a themed issue. So that issue is a success. And I think we can have success with PAPIS as a topical collection, but of course it takes the cooperation of my colleagues, and I need to expand my colleagues, and hopefully you will also be helpful in expanding my colleagues and in getting papers published in a topical collection under that theme. So papers will be able to be submitted as soon as we formally announce that we do have this topical collection, and the series will go forward. And I will be very pleased to accept manuscripts from both physical therapists and occupational therapists going forward, and hopefully in the very near future. So I want to thank you for listening to me talk and having gone on for a very long time. I guess I've gone on for 45 or 50 minutes. And I would now like to open the floor and take your comments and suggestions. Alex added this.
I thought, thank you, first of all, that was awesome. And I appreciated the broadness, and then the focus, the idea of PAPIS both speaks to me as an individual experiencing this, but also makes so much sense about it as a clinician. One of the things that I know this is kind of a loaded question here, but what do you see in looking from the outside into physical therapy and occupational therapy world, and then having known your daughter's experience, what do you think are best strategy to educate PTs and OTs against aggressive graded exercise and exercise therapy with PAPIS?
I think you have to draw on the experience with MECFS. I think in terms of aggressive activity, there is at least one published paper that shoots down the idea of aggressive graded exercise therapy, and that graded exercise therapy is good for all MECFS patients. And so I think by analogy, that can be argued. I think that one can reasonably ask the patients to try to dial back their activity for a period of 2 to 3 weeks and see how they feel and how they fare. One of the arguments that have been used by the proponents of exercise therapy is that the lack of exercises causes physical harm. And so what I think and what has been done for the severely ill, probably not published, is passive stretching exercise when tolerated. And I think that that is something that could be tried with a group of patients that fall within that category and see how they fare. I don't think when patients are that fair, I don't think it's fair to deprive them of a beneficial treatment. But for those patients who decline, I think it would be fair to compare.
Yeah.
So, and if there are enough patients, if you can garner enough patients, I think it would be a study that would be acceptable to peer review and literature review. I don't think that any one therapist will have a patient population that would support such a study. But I believe that if a group of therapists were to get together and pool their data and agree to a common strategy or protocol, that it would be possible to generate sufficient data. It would be a small sample study, no doubt, at least initially. But even so, small sample studies have been published. And so I think that's how one starts. You start with a small sample study, particularly if it has a promising result. And if it has a promising result, then it may encourage a larger sample study. I think there are probably large groups of physical therapists that we do not have access to. But if we were to publish a promising study, maybe we could go to the Mayo Clinic or the Cleveland Clinic and have them institute a nationwide study using a particular protocol. So,
hello. My name is Noel Greenspan. I'm from the Pulmonary Wellness Foundation. I want to say thank you for that talk. It was very fascinating and very interesting. I love your thoughts. I agree with many of them. I don't agree with all of them, which I think is par for the course with anybody treating either MECFS or post-COVID syndrome, or PAPIS, as I'm happy to call it, especially for the purpose of papers. I think we should carry papoose. But the other thing is that I think it's important that clinicians keep an open mind and really widely cast the net as far as differential diagnosis, because absolutely, I believe there are patients who are MECFS-like, but not all of them. At this moment in time, I have evaluated 295 long-haul COVID patients, and we've seen exactly what you referred to, variability away from that. And it reminds me of my EMS career when I had 3 patients, that one of them was a gangbanger that had a bullet lodged in his lumbar spine where he was shot. Another one was a patient who got bit in the buttocks by a shark, and another was an 88-year-old nursing home patient who fell out of her chair and fractured her coccyx. All 3 of them complained of severe pain in the ass. And if we had treated them all the same, probably the treatment would work for some and not for others. I love what we're currently doing a study where we're comparing exercise with and without oxygen to oxygen alone. And I think it's important to keep in mind that, again, not every patient with long COVID has MECFS. And I think that to necessarily restrict activity for all patients does a real service to some, but a real disservice to others. I would love to reach out to you later this week and share some of the data that we've collected with you, as well as some of our protocols that we are more than willing to share and make publicly available, as we have been since the beginning.
well, I welcome.
I think you're wrong. Sorry, I'm hitting the point of Long Island where I lose my signal.
And so he has. Yeah. Well, I welcome, sharing of data. The point is to be inclusive, not to be exclusive. The point of a broad definition is not to exclude. And if you know the cause, then obviously you have to treat the cause. But
Absolutely.
for MECFS, unfortunately, most times and most practitioners do not bother to figure out the cause. And it takes, quote, a specialist to be able to do that. We know at least one of the causes of my daughter's illness, which is Epstein-Barr virus. And when she's not feeling well, if you run an Epstein-Barr titer, the Epstein-Barr titer is up. So with the advent of antivirals, you can make her feel better by giving her a course of antivirals. And she does respond. Unfortunately, at this point, with the current pharmacological treatments, you cannot knock the Epstein-Barr out of her, nor can you knock it sufficiently low that she can recover. And my suspicion is that the virus has done other damage. It's not just the presence of the virus anymore. It's the damage done by the virus for having been in her body for so long that she, even if you were able to wave the magic wand and make the virus go away, that she would be able to get her life back as to what it was prior to her being infected with Epstein-Barr. So you have to work within the limits and the constraints that exist. But
Absolutely. Thank you so much for this.
Yeah, you're welcome.
Hey, I was just, thinking, because Sally and I, we talk a lot in our Facebook group, and we actually have members in our group that are also therapists that have long COVID as well, and then they have their own group, an international group of therapists who have long COVID. And how I envision it, I think for those, clinics that are trying to come up with treatments or whatever, I envision it like a flow chart, and for me, and Sally and others of us that know ME and the similarities between COVID and the differences between long COVID, is screening for post-exertional malaise, as kind of a beginning step. And, we know from Lenny Jason that he has his DePaul PIM questionnaire short form, which is short, which is good, that I think is a good start for therapists. And it also weans out, the patients that are depressed as well. And then, so if you do that short form and you're picking up on some post-exertional malaise, and you can, of course, then do the long form, which does take the patient a while. So the patient would, need to do it at home and have time to finish it. But I think based on the results of those two items, if you've got a long COVID patient that has, heart or lung damage, or is severely deconditioned, and they don't have post-exertional malaise, then you can proceed in a more traditional fashion. But if the long COVID patient is showing lots of symptoms of post-exertional malaise, then those patients would need, again, a flow chart to what we know that works, from decades of research and things, which is not graded exercise therapy, but is instead, heart pacing with using monitors, activity management, ADL work and things like that. So, I don't see it as an all or none. We in our group, we are not opposed to exercising a long COVID patient. All we ask is that they just be screened for post-exertional malaise, which can be easily done with the DePaul PIM questionnaire, and then those people taken down a different route. So if there's any belief that we're totally against exercise in general, I want to clarify that that's not the issue. We just want patients to be screened for PIM, in a easy manner that wouldn't take too much. And then if they do have it, then those are classified different than the ones that don't.
Right. No, not all.
I'm sorry, go ahead, doctor.
Not all patients are the same, and their, I'll call it mechanism of injury, is not the same. We have, well, I'll call him a patient. It's really a friend, but I'll call him a patient. There is this patient who became an MECFS patient in the traditional way. Namely, he received flu or contracted flu and became ill, and he just never recovered. And I'm going to say 25 years later, he needed surgery. And so in the pre-surgical screening, that screening revealed that he had a defective heart valve. And so prior to being able to do the surgery that sent him to the hospital, they needed to replace his heart valve and delay the other surgery. And subsequent to the replacement of the heart valve, he experienced a dramatic improvement in his MECFS to the point where he was no longer housebound and was able to go out and get a part-time job. So one of the things that I didn't say and perhaps should have said is that MECFS is a moving target, and that the assessments need to be cognizant of that. There needs to be constant awareness that it is a moving target. There needs to be constant vigilance to check for comorbidities, and that even though there wasn't a comorbidity on day one, that does not mean that there will not be a comorbidity 5 years later. And that the crappiness, for lack of a better word, that the patient experiences 5 years later may not be totally due to the MECFS, but might be due to the existence of a new comorbidity. And that is essentially clinician skill. And it may actually not be something that all MDs are willing to do, and it might be something that a therapist other than an MD might be willing to do by more thorough and frank conversation.
Agree 1000%. It is a moving target. Patients will not be the same every day or even within the course of the same day. And that is my point every time I speak to somebody about long COVID, which is that if our differential diagnosis only includes MECFS, then it's either yes or no. And I think we have to continually monitor. It's like a plane. We don't assume that because the last flight was good, that this flight is going to be good. And just to comment on the fact that, you know, I appreciate you saying that you don't argue against all exercise, but there are many in the community of all communities of physical therapists that are dead set against it and have actually warned people against participating in our study. So in the same way that there's diversity amongst patients, there's diversity amongst clinicians. And, you know, it's like I always say, if Thor gets into a fight, he's probably going to use a hammer. So the idea is that we've seen 295 patients. Many of them act exactly like MECFS. Many act very differently. And we would love to share these results and this experience, which is why we created our Wednesday night clinician and patient meetings. Again, keep an open mind, keep the differential diagnosis open, broad, and fluid. You know, we as humans like to put things into a nice, neat box. And if anything we know about COVID, it doesn't fit into a nice, neat box.
True. Yeah. Yeah. You know, long COVID is in its infancy. The bad thing is that there are going to be a lot of patients. The good thing is that there are going to be a lot of patients, so that we will get a large variety of symptoms, a large variety of expression of symptoms. I think it will be subject to meta-analysis, and there will be enough patients there to do a significant amount or significant meta-analysis to be able to perhaps figure out the different subtypes and perhaps even to be able to correlate it with specific genes or genomes that are present, and be able to explain the different reactions to the same or similar viruses based upon specific genes in the genome, which would be helpful. So, you know, that would be the end product. But in the meantime, I believe that there's an obligation to treat, and there is an obligation to treat not based upon a reflex, but based upon careful consideration of what we are dealing with. And I'm not sure that in these long-haul COVID clinical care centers that they are aware and therefore are giving careful consideration, which is why we wanted to put out that paper for clinicians about treating the MECFS-like symptoms in long-haul COVID, because there are three considerations. There are the principles that I articulated in this presentation. There is a pharmacological or pharmaceutical approach, which is published elsewhere. And then there are the non-pharmaceutical or pharmacological approaches. And all of them need to be considered. The clinician who is involved in managing the patient needs to be aware of all of it. And I'm not sure that's happening. So that's my concern. And I don't see guidance at the federal level.
On a personal note, you know, for me, I'm similar to your friend. I mean, I've had an MECFS diagnosis for 20 years, but probably about, I guess now about 3 years ago, I found out about a growing subgroup of MECFS patients that were being diagnosed with hypermobile Ehlers-Danlos syndrome. And I was one of those people, and subsequently diagnosed with craniocervical and atlantoaxial instability. And I underwent a cervical fusion a little over a year ago, and have had significant improvement of my symptoms, but I always consider, and I know now because of the EDS diagnosis as well as tethered cord, that I was born with those things, at what point, and a lot of the symptoms are similar, at what point it became ME separate from EDS, I may never know, but I've had lots of immunological testing, like you talked about with my MECFS specialist, and I have, reactivated HHV6, which is roseola.
Mm.
So, I'm real curious to see, what for me to have those tests done again and see if there's any change in that. But we're also seeing in a lot of these support groups, because I serve as a long COVID ally in a lot of long COVID support groups, is a lot of these long COVID patients are also starting to develop connective tissue disorders similar to Ehlers-Danlos. And so, I just have a personal theory that when all the research is done, that there's going to be a lot more known about the involvement of mast cell and mast cell activation syndrome, and how that's triggered, by an infection like COVID, and what that then, that the mast cells going berserk and the damage to the connective tissue, what happens with that, that may lead to connective tissue disorders and other problems like I had, so I know it's, because it's so new, it's in the infancy right now, but I do believe that we're going to learn, I think we're going to learn more in the next few years about mast cell activation syndrome more than we know right now. I definitely think that.
One of the things I haven't said, and probably should have said, is that certainly immunology is involved. And in my opinion, immunology is in its infancy. Several years ago, after I retired, I became an adjunct professor at, this one was at Castleton State College in Vermont. And I was asked to develop a curriculum for an undergraduate immunology course. It turns out that, at least at that time, there was no such animal. All immunology courses were taught in medical school. Nevertheless, I tried to put together an undergraduate immunology course. And looking at the curriculum of immunology courses, it's a spattering of this and a spattering of that. If you had a college level physics course, which is a spattering of this, a spattering of that, a spattering of nuclear physics, a spattering of electricity, a spattering of magnetism, it's all these little pieces that what is known, but do not make a cohesive whole. And in my opinion, that's what immunology is. We know these little pieces of what have been discovered, but it does not make a cohesive whole. And until there is a cohesive whole and we have a better understanding of immunology, we can't understand the immunological contribution to MECFS or any other disease that has an immunological component. And that includes EDS, and there is a connection between EDS, a known connection between EDS and MECFS. It has been found in a large number. I don't remember what that number is, but I've collaborated with, you may know the name Peter Rowe at Johns Hopkins. Peter and I have worked together in the past, and he sees a lot of EDS in his practice at Johns Hopkins, separate from and with MECFS patients. So I know from him.
Doctor, may I ask your opinion on on the usefulness and safety of back-to-back maximal cardiopulmonary exercise testing in MECFS?
I tend to be conservative about using CPET. A lot of patients have adverse reactions to it. And so my advice is that it's used only when absolutely necessary. There was the argument that CPET was the only accepted form of data for the Social Security Administration and the administration of, or the granting of benefits. My understanding is that that is no longer true. And so that if there are other ways of doing it without running the risk of setting the patient back, I would certainly recommend that those other methods be explored prior to CPET. I think there are a couple papers that have been put out about using other methods to demonstrate cardiovascular, I'll call it cardiovascular intolerance, that are less severe or that invoke less severe reactions than CPET. But it's still the gold standard. So, that certainly is patient choice, in my opinion.
I'd like to throw that out there because I was well aware of it for about 10 years before I chose to do it. And I was extremely well versed in the process, both with the individuals doing it on the East Coast and the West Coast, and decided about 6 years after I started following it to go ahead and do it. And it initially, naysayers are going to disagree with what I'm saying here, but I know what my experience is. It initially was blamed for my inability to return to work. That's what happened. But I will tell you this, it saved my life, because I was to the point that I had been for 25 years marginalized by so many people in the healthcare community, and was never given, any kind of meaningful, boundaries of a diagnosis that meant anything. It was, I by that point I had a diagnosis of CFS, but it was very ambiguous. It was kind of a flippant diagnosis that, oh, this is what you have. And it horribly minimized the experience that I had grown up with. And when I had that test, the first week that I was home from the test, I literally turned around looking for the weight that was on my back that I had carried for the 30 plus years that I had been dealing with this, and it was gone. And so initially my MECFS doctor did diagnose me with probably being in a persistent crash due to the test, which I was fully okay with, because I went into this completely knowing that that was a possibility. But I was also at a point where I could not go on any further without having this information. But over the last few years, what has happened is, I don't think the CPET put me here. I think what's happened is that my awareness, my ability to listen to my body and to develop my awareness of really how poorly my body functions has finally gotten me to a point where I can control my PIM, and my level of function is so poor. And my level of function actually now matches my CPET, whereas my CPET was so bad and my function level was actually way up here on a day-to-day basis They didn't know how I was doing it, but now the two are actually in line. And I don't have PEM hardly ever anymore. I'm not in pain anymore. You know, I live a pretty sheltered life, but the misery that I was living in, you know, is pretty much gone. And so I have, you know, there's a lot of, you know, yeah, there needs to be a better way, but there also needs to be an understanding of what it means to live like people do with MECFS before we ditch something and replace it with nothing.
Right. Yeah. And we may get to that point, because if we get a lot of long haul COVID patients who end up with MECFS or an MECFS like experience, it will bankrupt this country. 3 to 9 million people. I mean, Social Security was based upon actuarial tables, and this was not built into those tables. So they will be obligated to do something. And fortunately, Francis Collins has indicated that NIH is aware. And so one has to believe that there will be something. Whether it will be adequate, that I don't know. But there will at least be something, and that will accelerate the research and hopefully accelerate the results of that research. And I think if we were to put them all under one umbrella, then the research will go a lot quicker, because that even makes the patient population bigger. And so the investment needs to be bigger, because we're dealing with a larger number of people. And if we get rid of the stigma by having us included in a larger group, that will also be helpful. So we will see. We just need to keep pushing, and that's what I do. Unfortunately, the NIH at this point said 2 weeks ago that they are not going to include MECFS patients in the long-haul COVID studies. That, I think, is unfortunate, but we will continue to try to dissuade them of that decision and try and get them to include it. But all in all, I was going to put a slide in the presentation of where we have been and where we are and where we can go. And, it's all very promising. I think that in the year 2000, when the New Jersey Chronic Fatigue Syndrome Association lobbied the New Jersey State Legislature for an appropriation to fund and distribute a diagnosis and treatment manual for chronic fatigue syndrome, as it was then called, which we did. We produced a manual, the consensus manual for primary care and management of chronic fatigue syndrome patients. And it went to every physician, every licensed physician in the state of New Jersey. We did do that. And then we did have an educational program from the CDC. Unfortunately, they terminated it. There was a trained trainer program. My scholarship program, I still hope to get more states involved or develop a national program from it. We keep on improving it. We keep on getting wider participation. This year, not only did we have a great presentation out of it from Rowan, but we also interested a faculty member in MECFS enough for him to write a paper on MECFS. I don't think that's ever happened before. And, you know, if we can reproduce that experience this coming year, that would be great. I hope we can do that. And we will try to do that. And I keep on saying, I make the offer that any organization or state that can raise the money to do this in their state will be happy to administrate it. We'll share our question. You know, we'll find or create a committee to evaluate it at the state level through a school at the state level, and set them on their own course. But we just don't have the money to do it, but we're willing to do it. And hopefully we'll be able to spread knowledge, education, and clinical care. So that's where we are.
Well, this has just been so awesome, the conversation, and appreciate your input, Noah. That was great input and questioning and feedback. And thank you so much for taking the time, Dr. Friedman, and the presentation slides will be used by the group. The people that can't attend always go back and use them. So thank you.
You're welcome. You're welcome. And, I want to thank you again, Dr. Friedman. And may I ask your name? May I ask your name, ma'am? I'm sorry, I don't know you personally. You just spoke about the CPAD.
Oh, I'm Sally Radisky. I'm the main admin for the group.
Yeah, thank you. Sally, I want to thank you for sharing your experience on the CPAD, and I would love to discuss that with you further when we have more time.
Sure.
Just curious if you meant that the CPAD saved your life, or that because it forced you to stop working, not working saved your life.
No, the CPAT saved my life.
Yep. Okay. I would love to talk to you more about that, and I'd love to share our protocol with you and Dr. Friedman and anyone else who might be interested in it. Have a great day,
Sure.
everybody. Thank you.
Thank you.
Thank you. All right.
Thank you, Dr. Friedman.
You're
We'll be in
welcome.
touch.
Right. Great. Bye-bye.
Bye-bye.